Yeah, thanks. Hello, thank you for having me. We, as noted by the first speaker, we did not share these, so I'm going to be echoing a bit of what you said already, so apologies for any, no, I do not want to get on the online system, any duplication. I was asked to talk about respect for persons who make up the LHS. And I am going to do that I'm also, this isn't what I spend all of my time thinking about. I spend a lot of time thinking about genomics and return of results and all of that. So that will be woven in here, but I'm taking this in a very sort of straightforward way. And I'll be talking about it literally, like the literal use of the word literally. I will be talking about literally respect for persons and equity, and then what it means to take them all together. Oh, I'm forwarding it on my machine and not here. Sorry, you missed that slide. So respect for persons first. Of course, in the Belmont Report, respect for persons, which is usually expressed through informed consent, is based on individual autonomy. I am not going to be talking about informed consent here. That's the focus of the next panel. So I'm going to be focusing more on the second part of what it means to respect autonomy. So to give weight to an autonomous person's considered opinions and choices while refraining from obstructing their actions unless they're clearly detrimental to others. This was brought forward into the document, the Faden et al., so Beecham et al., framework for ethics in LHS as an obligation to respect the rights and dignity of patients. In interpreting the obligation to respect autonomy in learning healthcare contexts, we should assess both whether a learning activity unduly limits the choices of patients and the value of those choices to patients. To take one example that I'm much more familiar with, that of genetic and genomic testing, which has already been talked about by a number of other speakers. I mean, genetics and genomics is really sort of an obligate learning healthcare system case, right? Because I cannot tell you anything about the meaning of your genome unless lots and lots and lots of other people are willing to share their genomes and their healthcare data. It must be the case. Right, so this is it has to be a learning healthcare system in genetics and genomics. And it's where a lot of the conversations that we've had already about return of results has taken place. So given that in order to imbue any meaning in individual genomes, we need lots of data. We need lots of people to trust us with their data, right? But despite the fact, and this has been alluded to as well, we used to think that de-identified genomic data was risk-free as long as we kept it private and confidential. But increasingly, we know that that's not the case due to the fact that we share stuff online and people go to Ancestry.com, and there is more and more and more data about us online all the time. So these data are increasingly identifiable, which means that all of the systems we used to use to eliminate the informational risks of genomic research aren't working anymore, or at least not working as well as we used to think as well as they used to. So because of issues of identifiability, this research now comes with risks. And we have to think about what we can do in our conversations with patients and research subjects that will enable us to, in some way, mitigate those risks and maintain trust. I've argued elsewhere, and I'm sure many people in this room agree, that returning results is one way to do that, reciprocity, right? It is an expression of respect. It supports autonomy by not limiting the information people have upon which to make decisions and upon which to act, that second part of supporting autonomy. It has value to patients. We know most patients want these data. If you ask them if they want it, they will say yes. In particular, if they know that you're going to have it already anyway. If you have their data, they want their data too. So we know it has value to patients. It might offset the risks, the informational risks of participating in genomic research. And we hope it fosters trust. And I think this is particularly, and trust as the theme here, right? This is particularly important in learning health systems where we will be asking for consent less, right? And if we need to ask for consent less through authorization and notification and all of that, other ways of doing the research, there needs to be a high level of trust in the system. And this is a system, both research and medicine, that has frequently failed many of us. Which takes me to equity. So the Merriam-Webster definition of equity is justice according to natural law or right, specifically freedom from bias or favoritism. Faden et al., in their 7 obligations of a learning healthcare system, include an obligation to address unjust inequalities. I think this is fairly revolutionary, and I was thrilled to see it. So it was mentioned in my bio that I work across a number of different areas of emerging biotechnology. I tend to view each new area or new technology as a new opportunity to get it right. It being, innovation and governance of a new area of technology. And when I talk to scientists about this, and I'm a scientist myself, I say this with love, but still, when I talk to scientists about designing into the research and into the technology accessibility on the back end, they say we cannot be responsible for solving our social problems. Right? We can't, that's not on us. This is a bigger issue. We can't be responsible for doing that. I often say yes, but you could not make it worse, which is a lower bar, but would still be awesome if they would do. But so Faden et al. Actually said, we have an obligation to address it. And the problem has always been that if it's nobody's responsibility, if it's not the scientist's responsibility, if it's not the school's responsibility, if it's not the healthcare system's responsibility, it will never get fixed, right? And if it's anyone's responsibility, it has to be the responsibility of those professionals who are working in the service of improving human well-being. So I think this is the place to do it, but it's a heavy lift, and we have to be quite thoughtful about it. So we know that there are differences in access to care, right? By socioeconomic status, racial groups, ethnic groups, geographic differences. We know that different hospitals have different patient populations, right? I have a couple of different focus group-based projects. I have one in working with folks at Brigham and Women's, where our sample of focus group participants was almost entirely white, and almost every single one of them had college or graduate degrees. That's not the general public, and what works for them is not going to work for everyone, and the care they have access to is not the care everyone has access to, right? Or I trained at Case Western Reserve in Cleveland, where we have the Cleveland Clinic, the Borg, Resistance is Futile, which is similar to Hopkins, a huge hospital system taking over everything. And then there's the community hospital system. And they have very different patient populations. Different sides of town, very different patient populations. So where is the learning health system going to happen, and who's going to benefit from that, right? Thinking about how individual learning health systems and regional health systems are going to work to deal with issues of equity. Where will the learning health system be? How will information be shared across hospitals? Within an individual learning health system, how will information be shared with patients? Right, you brought this up in your talk, in particular about the health IT stuff, right? How will preferences be solicited? And I've done this much research in learning health systems, but I'm very familiar with another system where there's a lot of disparity and communication is hard. So my kids go to Baltimore City Public Schools, and communication and engagement across diverse populations is really hard. And it's especially hard to do it well. And we need to be thinking about these issues, and I know many people are, but we need to be thinking about these issues as we design these systems, because this is an opportunity to get it right. Oh no, I pushed the button. Oh, it went better. Having two computers up here is confusing to me. Does that get me back? Okay. So then specifically with regard to equity in genetics and genomics, I mean, you've already seen the slides, Vence Bonham slides. There have been other papers as well demonstrating that who we sequence is not uniformly distributed across the population, right? And there are, the nature of genetic data makes it such that who we sequence matters with regard to who then has access to what we learn from that research, right? There are differences in the level of variation and in allele frequencies across populations, and that has implications for the meaning that we draw from those data. So having a failure to have just distribution of those data bakes in problems for downstream access to benefits. And we also know that populations who are underrepresented in genomic data are also more likely to have low levels of trust in science and medicine. Right? I come from Johns Hopkins. I have spent the last 7 years talking about Henrietta Lacks and working with her family in groups in Baltimore and talking to Baltimore City kids about what Hopkins did. And in this case, I would certainly argue that it's actually us that they don't like. And it's totally fair. So then bringing it all together. So respect for persons, just to recap, respect for persons demands both support of autonomy and non-interference in people's ability to act on information. Inequality exists in the healthcare system, totally obvious, and in genetic and genomic research. We have an obligation not to recapitulate or exacerbate existing inequities in our systems. And this is really my point. Baked in is better than post hoc, right? It is, and this is what I say to scientists all the time, it is so much easier to design a system to make just access to benefits easier than it is to design the system, ask who has access, and go, well, it's too late, we can't fix it, right? It becomes a much heavier lift at that point. So how do we do this? I don't actually know. But as a baseline, we of course need a truly functioning learning health system in which knowledge is translated into improved care, both within individual learning health systems and across hospitals. We need to ask the question from the beginning, will everyone benefit equally if it's designed this way? Right, so in the case of return of results, if you're doing that via a patient portal, right, okay, who has access to the patient portal? Not everyone has one of these in their pocket. Not everyone has internet at home. If someone needs, in order to get access to their information, they have to wait until a time that they can go to a public library and access the computer for a 15-minute slot. That's a very different level of access to benefit than people who can download it in an app on their phone. Engage with patients to identify mechanisms to ensure equitable distribution and utility of benefits, and then do the research. Who's accessing the patient portal? Like who is actually logging in? You can find out that information. Who's asking for their data? Who isn't, and why not, or why? And then the next step, and I think this was alluded to on the first panel, are people able to then use those data equally? right? I now have access to the data. Can I actually do anything with it? Do I have access to a genetic counselor? Do I have access to the care that these data would suggest I need? Thank you very much.
Thank you. So we've had the luxury of a panel that's not afraid to take audacious stands, which is always fun to see. So since this whole session is focusing on equity, that's our goal, then what I had the chance to do, because Jody and Kate were so generous about sharing the planning committee's thoughts and the committee's slides ahead of time. There wasn't active collaboration on who said what then, but there was the opportunity for collusion in looking at what themes might be warranted to consider. And what struck me was that this is the group. This is the group that's in the position to really think prospectively and intentionally about what are the practices that we're thinking about with LHS that could actively promote warranted trust. So if we're going to be intentional about this, what are the practices that we're seeing that we could communicate, celebrate, that actively promote warranted trust? And Ken started us out as did Ann, with thinking about things like we already are seeing really differences in policies towards organ donation from opt-in to opt-out sessions, then that still have enormous threat to equality in terms of who's actually going to have access to the organs. And, are you in an urban or a rural setting, then how much you're going to be able to pay? What's the social support that you have afterwards? That person who's going to drive you home from the hospital, as we heard about in the session earlier this morning. So as we're thinking about these systems where what we elicit for information in the LHS, what we make sense of in terms of our analysis, and then how we share information, what strikes you as policies to promote that we're seeing now that actually promote trust in our system?
Hear that, will you? Well, if I might, one of the things that occurred to me about trust, those of us who, for example, have advocated for lots of different technological advances, ranging from stem cells to more budgets for studying interesting molecules to translational science, have had this gnawing anxiety or worry that all the people who we want to participate either in the randomized double-blind placebo-controlled trials to the simple information gathering that we need across the board would be forgiven if they said, I'm going to participate here, whether it's risk or not to me, but it matters more if it's a risk, to generate new treatments and drugs that I can't afford. Yeah. Well, you all talk about trust, and you talk about partnership, and you talk about raising the bar for public health, and you talk about the health of populations. But what I see, and I've seen for my entire life, I don't see it getting better, is we don't actually share very well. You talk about equity, we don't have equity now, depending on the population that you're in. So why on earth would I want to put my thumb on a scale that produces more good stuff for those who've got and nothing for those who don't? When in fact we know your databases need to have both if they're to be of any use. Let's reduce that disparity, that inequity, that a bit of failure of civilization, and then I'll give you all the data you want.
All right, we're going to go ahead and open up the floor to questions. If anybody would like to address the panel.
Oh, come on.
They just agree with everything we said.
Okay, here we go.
We need plans.
Let's do something
We
interesting.
need to get the mic across the floor.
No, that's what you said, Dr. Goodman.
So, Ken, this is not well formed, but. Oh, sorry, go ahead. I can form it better one. So Ken, this question's for you, and it's the notion you put out there that people who opt out of data sharing or might be sort of willing to rely, like sort of stand on the backs of the people who are willing to share. I'm curious what your empirical data will say. I would suspect there are a subset of people, and I might even put myself in that bucket, who get all the vaccines prescribed, who've been an organ donor since day one, who is data driven when it comes to gun violence. But those are quantifiable risks. Everyone knows the risks of getting a vaccine quite low. Everyone knows the benefits, both to individuals and society. That balance seems to weigh in our favor. I think what makes data sharing categorically different is that the risks are not known, not quantifiable in any kind of way. So, we're talking about it in the context of good actors trying to do good, trying to make our health better. And I wish those were the only players in the world. I think when we talk about data being sent out into the ether, hopefully to good actors, there's no guarantee that bad actors can't have access to it. There's no guarantee that they can't use access to our data for nefarious purposes. And so I think building those considerations in is warranted in a way that I think the analogy to vaccines doesn't necessarily bear out. Let's put that out there.
So that's a fair point, Elizabeth. One of the things I've noticed, part of it is you were arguing from what we don't know. I like to make distinctions among risks, harms, and wrongs. I think it's possible that I can be harmed in different ways, although it's like I'm looking for a good example of somebody whose health data has led to them being harmed, other than the fact that they had a pre-existing condition, right? It might be that I've been wronged in different ways, but it's possible to wrong someone without them even knowing it. What I'm struck by is how, in my own behavior, I will go online and I'll buy something, or I'll transfer money from my bank account to pay for something. And there I am watching in the lower left-hand corner of my browser the magic of the click stream, and how Google and Amazon and Citibank and American Express and Bank of America, whatever the bank is, and they are all scarfing this data up by the shovelful, involving my income, that of my family, that of my Social Security, that of stuff. And I look at it and I say, well, but at least I got to buy those that widget quickly at a price. You say the same thing in my health data. I say, well, wait a second, that's my health data. I wouldn't possibly want to run that risk. I take your point that there's something interesting about health data but I would have thought the same thing was true of financial data. And I've noticed that we've taken completely different stances. Financial data, whatever, the convenience is worth it to me. Health data, it might help you. I'm not so sure anymore. The risks are too unknown for me to take. And I'm not disagreeing with you. I'm saying I have the same intuition, but I don't like my own intuition. What's the difference?
Well, we should be more protective of those other kinds of data.
Indeed, we should, but I guess what I'm trying to say is, since we're not, we throw caution to the wind when there's no benefit to the community. When there is benefit, when it comes to health, that's when we become suddenly really quite cautious. And it's sociological observation, not an ethical one. But I don't see the difference actually, other than that one's commerce and the other's being commodified. I haven't gotten there quite yet.
Well, I think one of them has governance structures associated with it that we can identify, and the other one doesn't. Right? So we're having the conversation around health data, whereas we're simply not having that other conversation. And to your point, Lizzie, and your point earlier, Ken, about the co-occurring characteristics of individuals who don't want to share their data. I mean, something that really struck me, actually, John, that you said in the commission meeting those many years ago, was that in this space, in genomics specifically, right, we, as you said, don't know exactly what the risks are going to be. And what you said was that we need lots of people willing to take arrows in the back, right, and be open to that risk now, not knowing exactly what it is, in order for us to move forward and get past this space and into the nirvana where it all works well. But in a learning health system, I mean, I'm not willing to ask the people who have been systematically disenfranchised to be the ones to take those arrows, right? And that's what I worry that we're not sufficiently attending to that in the move to learning health systems.
Oh, I think we agree. I mean, I didn't make the point clear. Until there's no reason to trust any of our efforts.
Yeah.
Without that population saying that's the old switcheroo over again. Unless you can't provide basic public health, the drugs are too expensive, the doctors are inaccessible, the emergency rooms are closed, and now you want me to contribute to your learning healthcare system?
Yeah.
I mean, I guess what I'm saying is the disparities we already face. It's the moral obligation to share data, sort of with a, forgive the phrase, it's sort of cateris paribus clause. All other things being equal, I'm a free rider on all the ways, including healthcare, but I'm sort of stupid if I also don't take into account what you've just said. Why would there's altruism without any reciprocity ever is what? Not well advised. So we need the best. I think the best minds in Washington are working on this right now.
That was a mean thing to say.
What's that?
That was a mean thing to say.
No, present company excluded.
My question is about reciprocity and return of results to the community. I work with a lot of local health departments. So I got very excited when you said Jon Snow couldn't do today what he did back in whatever. So I went and I said, oh, I wonder if there's a heat map of Jon Snow's findings. And of course there is. It's depicted in a zillion different ways. And so I'm like, okay, public health could have collected that data. If Jon Snow is a public health epidemiologist, he could. But I don't think that a local health department could have reported out that data to the community because heaven forbid it's too granular. And so when I'm having a challenge in helping local health departments find a legal way and an ethical way to be able to return results to communities that are in small enough geographic areas and specific populations so that they can actually have meaningful data and neighborhood organizations and others can do something with it. Any ideas?
So, yeah, I'm sort of familiar, I think, with that challenge, and as well as sort of the larger challenge that public health departments, especially at the county and state level, are dealing with, so sort of this harmonization and merging of all these sources of data that they're somehow responsible for, and they're like, oh my God, this isn't going so well, and there are lots of gaps, and yet the gaps also reflect sort of where there are problems that we want to address with these underserved or vulnerable or at-risk or whatever you want to call them, sort of communities and groups. In that particular case, I kind of wonder if you can start, I'm thinking about Mike Burgess, actually, a conversation we had last night, that maybe it's time to talk with the local community about that return potential and sort of where are the benefits and risks and where do they lie. And maybe not everyone agrees, certainly, and I wouldn't expect them to, but is there a way that they themselves can work with that local county department to come up with a rational system to return? Or, there's like in the PMI, there's the time frame sort of lag idea, right, that I've read about, sort of how can you think about that over time? Are there aggregate ways of returning information that's relevant for the neighborhood, the community, right, that in itself will be meaningful to advocate for changes that are maybe more on a macroscopic sort of policy level change, or even a practice change in their local community, whether it's a utility or whatever that is the actor that you need to engage with. But there are ways to think about it, but it's going to take time and money and investment in community engagement, which is always the issue.
I could add, we have the sad occasion to celebrate someone who did that in Michigan. So it was a brave pediatrician who on her own time said, what's going on with the blood levels in the kids I'm taking care of, and just tirelessly did the t-test that she learned while she was in medical school, tested it out with friends in other health departments throughout the state and nationally, and decided that she needed to voice this. And she was ridiculed initially, really persevered. But what she was able to do in Flint, taking care of that group of kids, then was astonishing. And she was able to draw on tools because there was pooled data then, so that you could look at trends over time and trends over different areas. And it was essentially this one brave woman, pediatrician from yet another Michigan medical school, not ours, that was able to make this case, but also to stand as, I think, an example to celebrate of if that really is your focus, if that really is your focus, is the health of this community, and I'm going to look at the existing data and give it medical coherence in terms of the, not just trivial differences in lead, but these are clinically significant. That if we empower people to be champions, we've already seen examples where people are willing to do that. So maybe some celebrating of these kinds of stories.
Well, and to go back to your phrase, which I really liked, warranted trust. It's not just trust, but actual trust that we've earned, right? You're going to have to talk to people. There is no other way to do it but to ask people how they can actually benefit from the work that's being done. Both at the front end, a lot of what we've talked, there's been a lot of discussion of, asking what are the questions that you have that we can help address with the tools that we have, but also then at the back end, although preferably you do this up front too, how can we ensure that you actually benefit from the work once it's done?
And that you understand that you're benefiting.
Yes, that you understand that.
And so reminding people of that track record. From lead to, does anybody remember the first research on seat belts and accidents in motor vehicles involving kids bouncing around? Really awful data about human injury that was collected from all sorts of reports. I mean, the entire history of what we've come to rely on from our county, state, and federal health departments is a history of people of goodwill saving lives and reducing suffering, and everybody was fine with it. And look at the lives, in fact, that we've saved. It's more probabilistic now, the benefits aren't clear, but we've also had some erosion. I mean, now in my state, if a pediatrician wants to ask a family about whether there's a firearm in the house out of concern for gun safety, that's actually against the law in Florida. Because that would be big government infringing on people's rights to have guns. So you pays your money or takes your chance as we shift back and forth. Now it's in the courts, of course, but imagine punishing a pediatrician who says, do you have an unlocked firearm in the house? What's that about? Why are we having to defend public health in the face of that?
Other questions?
Actually, can I make a quick comment?
Oh, sure.
Sorry. I think there's a couple other sort of practices that I draw upon from public health that might be valuable. One is, we talk a lot about sort of these challenging topics like trust, uncertainty, probabilistic notions, et cetera. And in public health, there's been a lot of efforts to be able to change the social norms by which we sort of see health in the world, right? And that some people think very, disparagingly, and think of that as sort of another type of social marketing, right? Social construction of sort of our realities. But I think that there's something to be said for how do you employ sort of those norm-changing sort of approaches. Again, with transparency is what's required, right? To be able to sort of shift the balance of how we think about things like security, how we think about, just recognizing that like your bank accounts are probably insured, right, for the FDIC. That just engenders not only as a policy and as a practice, but also as a sense of, oh, I know there's something kind of holding me up underneath there. So if I get totally taken over, there's some actions that I can take in terms of my identity and my financial records. Similarly, in biosecurity and sort of this world of security that we all live in now as compared to 20 years ago, right? There's been a lot of effort to change the way that we sort of see the world, for better or for worse. But I think that, there's potential for that, but it is this sort of question about social engineering that we have to be mindful of. But again, learning health systems and the providers and the systems there are in such a position of power to be able to affect how we see health, right? Remember, like Robert Wood Johnson Foundation, culture of health, sort of this idea of where we sort of move our society, how equity itself, health equity tries to place health and as the principal sort of goal, and that changes the ways in which we choose to govern ourselves, right? So think about sort of those scales of change that we could be engaging in with evidence, right, that we look into our own health systems.
I wanted to suggest there might be other ways of approaching equity in learning health systems.
Oh,
Quiet?
so that's
Is that
better.
Although the radio has been up. I want to suggest there might be ways of using public engagement to improve the way we do represent equity in learning health systems by letting the learning health systems as they evolve with upfront public engagement shape our understandings of what the health and well-being issues we're trying to address, because communities tell us what they care about.
Right.
And based on the fact that they value what they know now know that people study, they will then take risks and trade off privacy, because they've helped shape the benefits that they see. So rather than thinking about learning health systems as trying to negotiate the challenge of privacy and individual consent against communities, think about communities as helping construct the benefits so that they together agree that the risks or the changes in privacy protection and consent are justified by the benefits that they want to achieve.
Yep. You're here.
Well, thank you for your really excellent points. I really appreciated Dr. Goodman's really very strong thinking about the obligation to participate, and you benefited from what everyone else went through. Others have a sort of right to benefit what he went through. I see another equity perspective is balancing sort of relative power between different kinds of stakeholders, with patients and we, the public, being one, or public health and patients being sort of two different related groups, and then lots of other stakeholders. Stepping outside of healthcare for a second, so something that sort of made me think about this balancing a lot recently is Equifax, which is, I guess, 4 or 5 months ago or whatever it was, they had a breach. They told us about it 2 months ago because they needed to sell their stock and do all kinds of sketchy things. That was almost half, I think 140 million, almost half the country had some of their privacy breached. That's some really important thing to delete identity theft. And I as a customer, or whatever I am upset and don't want to do business with that company, as a lot of people feel. And that's when it kind of hits on us that we don't have a choice, because we're not the customer. 140 million of us were affected, but we're not the customer. We didn't play any real role in deciding about sharing our data or not with them. And we're sort of the raw material and not the customer. And I guess the analogy is, to me, that's the extreme we never want the learning health system to go to. Maybe the other extreme where the privacy people keep everything in and out of it. How do we think about that balance? How do we make sure we don't go to that far, if that sort of guidepost makes sense? And it's great to trust too.
It's not like it's not like our economy evolved based on principles of equity either, right? I mean, all my investments are tied up in soda bottles, and the disparities there. I mean, I think that the credit situation is rigged with disparities depending on where you are in the community. There's no legislation. We have basically created a moral resort area around health information, having watched what's the emotion? As we watch people who have income disparity that you can't imagine, who have a disparity when it comes to workplace, who have disparity when it comes to discrimination. There's education. Thank you very much. Maybe the most important one. And what we've done is we've said, well, what have we done? We've privatized our schools in response to that. Thank you very much. So now we're saying, well, we really want to build learning healthcare systems, and we want the people who have done that to support us when they never saw the benefit they got from the community in the first place. I'm actually worried about asking, just to push the point a little. I'm not sure I want communities to tell me what they think they want. Because depending on the granularity of the community, you might get people doing things like, I don't know, voting. Do you really want to subject public health to that kind of I think we need to listen to them more, but I think part of what's happened is, it's not that one, we haven't listened, and two, we haven't worked together well enough. There's no relationship between our academic medical centers and the communities. It's not that they need to be guiding us. We haven't been listening at all. And that two-way street, the idea that I think most communities actually have a great deal of respect for academic medical centers and for teaching centers, and what they will get from in the future learning healthcare system. But I don't think we need to make that a partnership and a constant exchange, as opposed to how can we help you? Because if you ask that and you think that it poses a duty on you, you might find yourself with some very kooky duties. But that's what we've discovered with Equifax. You bought the ticket, this is the ride, and it's not covered by your $100,000, right? There's investments all over the place that are not insured at all. And if those are hacked, then I'm really harmed. And it was, oh well. It's called When Wall Street Collapses. I'd like to be protected from that. Thank you very much.
I think someone said earlier that there are some things that are very low risk and make all the sense in the world to do, and we should just go ahead and do them, and they don't require community engagement. It's the stuff that bumps up above low-hanging fruit or minimal risk that we have to talk to people. I mean, we just do. And I mean, I really do believe it goes back to an obligation basically not to make things worse and to make things better if we can. And I mean, I would love to do it in education personally. If I got to choose a sphere of endeavor, I would do it in the education system, not in the healthcare system personally. But this is an opportunity to do that. And I think we have an obligation to do that. And yes, maybe if they say, if we go to a community and say, what is it that you need? And they say 6 more corner stores, or, I don't know, something that would be like more parking lots, fewer parks. Yeah, okay, we're not necessarily going to work with them on that. But we have to have the conversation and figure out what it's actually important to them that we work on.
I think that's right. And also our history, they will be forgiven for saying, oh, now you're interested in community-based participatory research. You must have gotten a grant for it. Right, I mean, in other words, our partnerships with our communities are need to be improved. They all need to be improved. I mean, the communities we're talking about, they're not stupid. They know that we come around when there's going to be a peer-reviewed paper here, there's going to be a grant there, there's going to be some way or other that my institution will, as opposed to really sincere connections with the lives of ordinary people. We now need to demonstrate those academic bona fides. And we can start, I think, with education. We can start with helping people financially. A little bit of financial literacy, I think, will go a long way. But I think that it's a long road, and our track record is not good. And getting that right, I think, is necessary for the success of learning healthcare systems.
And actually, I'd like to take back something I said. So when the community group says more parking lots, fewer parks, we need to find out why. Right? And what is behind that? Maybe it's because parks lead to violence, and there's something else that we're not getting at, but we have to listen and ask questions to actually get to the answers.
Another sort of facet that just this discussion is reminding me of is the workforce development question, right? And I say that because what I've noticed over the past 20 years, in at least the public health circles that I work in with health departments, et cetera, is that many of the people that I worked with early on who are doing community work, who were really sort of coming at it from that perspective, and they have developed, they've partnered over time and worked within the public health system and are now people working in public health, like, in the county health department. There are people working in the state health department. And the point being is that there's been this shift in the workforce in very positive ways, in my opinion, that, again, blurs or dissolves this barrier between who's playing what roles and what those divides are. And I guess I vaguely remember in reading some of the background on learning health systems that that's another area that we ought to be thinking about as a place that we could, we see that also in the academic research setting, right? Like, that's why the NHGRI gave me a waiver to work at 50% on a grant that I'm supposed to be at 75%, right? Because I was able to argue the vision of working within communities to do this research. But it required a policy change that involved 20 people, or at least an exception made for me. So again, how do you govern to create equity in the work that we do, right? Think it through sort of the whys of the logic and how it all works to your end goals.
So we have time for maybe one, maybe two more questions. Karen, did you?
Yes, this question just builds off of something that Josh was saying, which is that in the case of like Equifax, we're not the primary customer, really we're
The product.
In some ways. So the question I had was, when I think about research, I think of who's the customer for research, who's the short-term beneficiary, and in some ways, I would argue it's the researcher, because it's the new knowledge that's generated that's eventually going to help people and patients. With quality improvement, the immediate benefit maybe goes more directly to patients, because the thing you're implementing, you're thinking is kind of an obvious, this should help type of a thing. Who's the beneficiary in your kind of views as a panel for a learning health system?
I see we're out of time. Humanity. Right? Wouldn't it be? And by the way, we're in North America now, and one of there are actually several countries in North America. The others that are civilized have fewer problems. Wouldn't it? I mean, but we look at travel, we look at the flow of data across populations. I would like to learn from healthcare systems in France and Ecuador and Thailand as well. I mean, I think the goal here, and especially if we're looking for real in a world in a world of genes, wouldn't it be interesting if and ubiquitous travel? I mean, in my community, we've been dealing with Zika a lot lately. So frankly, what local is sometimes hemispheric. And we see this every once in a while when some bug gets out of a box somewhere, and everybody in the world starts thinking, I wonder what y'all do for Ebola here, right? How much money did your hospitals find when there was no money to buy a bunch of personal protective gear for people? There was no money for a bunch of other stuff, but we found that pretty quick, didn't we? Wouldn't it be nice to know about emerging diseases in Africa? Wouldn't it be interesting to find out in terms of environment and climate change how those emerging diseases are emerging, and how even though it's going to be somewhat cooler here than in Florida, I'm here and you have no idea what awful diseases I brought with me. So I want the answer to that to be big and bold and wholesome, namely civilization. And so that somebody will say, wasn't that naive? So I can say, absolutely.
I would love for us to design a learning health system in a way that different aspects of it lead to immediate benefits for many different people, right? So quality improvement, yeah, that should, if your system is functioning, lead very rapidly to improved systems and improved care for everyone in that system. But if we're actually engaging with the publics around our institutions, that in itself is a benefit.
Absolutely.
Right? At Hopkins, the hundreds of people, all the faculty at Hopkins, how many of them actually live in the city of Baltimore? Not many, right? So we have segregated ourselves in ways that make engagement much less likely to happen. And so if the learning health system leads to more engagement between the hospital system and the people that we live next to, that is a benefit right off the bat.
It's promoting more into
That will pay dividends down the line as well.
Any last comments? All right, please join me in thanking this tremendous panel of experts.